and welcome to a special year-end edition of the Johns Hopkins 30-minute COVID-19 briefing. Today, we're extending the briefing to a full hour, and we'll be providing live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. For the next 60 minutes, we'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. As part of this briefing, we'll have an opportunity for live Q&A with our experts, and we'll be sharing our new COVID vaccine tracker tool, which just went live moments ago. Due to the upcoming holidays, this will be our last briefing for 2020, but we'll continue to offer these briefings regularly in 2021 on Fridays at 12 p.m. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. We'll be providing answers in real time today, so please submit your questions in the box at the bottom of your screen. Today, I'm joined by 4 guests. Beth Blauer is Executive Director of the Johns Hopkins Centers for Civic Impact. Beth will provide an overview of global, national, and regional COVID-19 data and trends. Dr. Jennifer Nuzzo is a senior scholar at the Johns Hopkins Center for Health Security and an associate professor at the Johns Hopkins Bloomberg School of Public Health. Jennifer will give an update on the public health implications of the COVID-19 data. Dr. Bill Moss is Executive Director of the Johns Hopkins International Vaccine Access Center and a professor at the Johns Hopkins Bloomberg School of Public Health. Bill will give an update about COVID-19 vaccines. Finally, Dr. Brian Garibaldi is the Medical Director of the Johns Hopkins Biocontainment Unit and an Associate Professor at the Johns Hopkins School of Medicine. Brian will give an update about the treatment of COVID-19 patients. I'm now going to turn to each of our speakers for a brief overview. Beth and Jennifer, public health data has played an unprecedented role throughout 2020, and there's every reason to expect that the public will continue to be interested in COVID-19 data as this pandemic continues to unfold. Can you talk us through the major trends that you're seeing and also give us a preview of what to expect with the vaccine data?
Yeah, sure. So I'm going to go ahead and share my screen. Can everyone see that? Thumbs up. Great. So very exciting day for the CRC today because we are now live with our vaccine data. So when you are on the site and you click onto the vaccine tab on the main CRC landing page, you're going to see a map that has the United States rendered. This map represents all of the states that are currently already sharing vaccine dissemination data. So the states that are appearing in blue are states that already have that information shared. When you click on to each of those states, of those blue states, you'll go to their region pages. On their region pages, like this one for the state of Michigan, you can see some general overview data of what's happening in that state. But now you have the vaccine tracker, which is going to be developed as we get more information. So as you can see, to date, they've administered 1,410 doses. And then we also are showing the very last day of data that we have. So you can see that data moving and understanding the impact that the vaccine is having and how high of a level they're able to disseminate. There are only a handful of states, Ohio, Michigan, Texas, Nebraska, California, Pennsylvania, Idaho, and Washington that are sharing this data in a way that we're able to get it into the data resources. This is going to be updated. We are really looking forward to evolving the way that we're tracking vaccines. A few things that we'll be holding for. One, obviously, one of the things that Jennifer and you and I talk a lot about are standards. So hopefully we'll get some standards around how the vaccine data should be shaped and framed. As new vaccines are approved, so we know that emergency use authorization, and I know Dr. Moss is going to talk a little bit more about that later in the briefing. As we get more vaccines approved, we're going to get the number, the baseline number of what's being disseminated to states is going to increase, and we're going to see this administration data also move. And so really excited about this data resource. Hope that it is helpful that to have all the states in one place, we're going to be able to really leverage this. Also being able to see the coverage, the vaccine coverage against the case data, I think is a really important point as we continue to really fight in the heat of this virus, to be able to show the sort of level of response up against the data is critically important. Jennifer, anything that you want to say about the significance of having vaccine data up on the site?
Well, I think since the beginning, we've been trying to track not only the epidemic itself, but also the response. And that's why we added testing to the site. But now that we have a new tool in the fight against COVID-19, tracking how quickly we're rolling out the vaccination campaign is, I think, an important dimension to understanding, what trajectory we're on with this pandemic and, how long it's going to be until we have some level of protection in the community. So I'm really excited to see these data become available and really hope that more states can share information regarding their efforts on this front.
Yeah, and we're going to continue to monitor the way that the data is being shared at the state level and local government levels. We'll also have an eye towards data that the US government's sharing. A stunning release in the last week on hospitalizations, which we're going to talk a little bit about in this briefing, that came out of HHS, and we're hoping that that's just the beginning of a trend of more data coming out of the federal government and really helping us shape and frame the work that we're doing. I want to start to really think about globally, kind of where we are and some trends that we've seen in the data. The virus is still very much alive globally. I think that we are very focused on what's happening in the US because the US continues to be a leader. Since just last Friday, we've had 1.5 million cases just in that short period of time. We are still leading the pack. Here you see in green is the line for the US. You see also this orange line, which is actually Turkey, where they pushed a lot of data out there around the disease, but they're actually leveling back out. You're going to see their data continue to level, but you're still seeing the US climb. The cumulative case total in the United States crossed another sort of devastating threshold. We hit that 17 million mark. We're at 17.22 million. And Wednesday of this week on the 16th, we reported 247,403 cases by the end of the day. It's the highest single day total since the beginning of the pandemic. So we are very much still deeply impacted by that, and that is really manifesting in the data that we're seeing in the United States. Jennifer, anything you want to add just at the sort of high level around the case data and what we're still seeing in these trends?
I think globally, some lessons learned that we're seeing right now is that a number of countries that had been doing well are also struggling. And so while the United States clearly is still the leader in terms of having the largest epidemic in the world, and at the rate that our cases are climbing, we will probably continue to lead for the foreseeable future. But a number of countries, particularly in Europe and also even South Korea, are now have been as of late seeing rise in cases that exceeds their spring levels. So I think the overarching lesson for countries is that they remain vulnerable, and that the successes must be maintained. Otherwise, the virus comes raging back.
Absolutely. And we're also seeing, here in the United States, very much every state is beating their own records. So we're hitting highs in every state except for New York and Hawaii. That the pandemic has really had an impact in these places now. This is the moment that these states are fighting the most difficult circumstances. And so one of the big stories that we're really tracking in the data in the last week or several weeks has been what's happening in California. This is a still from our daily video that we provide on the CRC homepage. And really what this is showing is just how pronounced the outbreak is here in California. We've seen some incredible policy decision-making that's happening at the local levels, particularly in Southern California, where the governor and the mayor are really partnering around the data and really trying to figure out the best strategies to keep people safe, to keep people home, to keep people masked, and to keep people from getting the disease. We're seeing hospitalization data also really being stretched to the max in California. And so, it's an incredible time for the data. And I know that these decisions are not easy for our public policymakers, but they are really the most critical tool that we have to fight the pandemic. And I don't know, Jennifer, if you want to speak specifically about what you're seeing in California or some of the decisions that we're seeing from a public health perspective.
I think this kind of orange squiggle, which shows the cases over time, is a really good example of this ongoing challenge, where you have a state that was, acted early. Those actions help bring down its case numbers. But then, as soon as you start releasing, if you don't keep up with the cases that inevitably start occurring once restrictions are lifted, if you're not able to do targeted interventions like testing, contact tracing, isolation, and quarantine at a sufficient level, the virus just spreads, sometimes silently, until suddenly you see this, it's like an iceberg gets uncovered, this huge resurgence in cases. And that's clearly what seems to be going on in California. Really worrisome situation on the hospitalizations in California, record highs there, to the point where they're talking about crisis standards of care and other really serious interventions. And so, I think this is the keeping trend, not just in the United States, but around the world, which is the need for continued vigilance and how quickly accumulating cases can begin to accelerate.
Absolutely. And, I think that one of the things I also want to call out is that it's not just the case data that's gotten alarmingly high in many, many states. And that's not to say there are some states that are continuing to use these levers of public policy to manage their case loads down. So we're seeing some trends in declining cases, but we're seeing deaths also at a stunning rate, very high. We had, north of 3,500 deaths, 3,656 deaths, just in the most recent reporting period, and we're continuously sort of hitting these highs around deaths. And want to know a little bit, Jennifer, from you. What do you think is driving this? What do you think the implication is on our hospitalization? What does this mean from a public health perspective?
So cases lead hospitalizations and deaths. And so it's inevitable when you see a huge spike in cases, it's inevitably those cases are going to spread, particularly, first of all, we will see more of all age ranges begin to become hospitalized and die. But, any hope of particularly protecting those who are known to be most vulnerable to the virus, it becomes much, much harder. And so, in this last week in the US, we have crossed the 17 million total case threshold. We added 1 million cases in the span of 5 days, and we have reached record high death numbers, daily death numbers. That we are pushing to 4,000 deaths per day is really unfathomable, but that's unfortunately what we're seeing. And if we remain on this trajectory, the numbers are just going to continue to accelerate.
Yeah, I think that we're at 307 here. But it was only September 21st where we were at around the 200 mark. And so we're also seeing that time condensed, which is, really going to have downstream effects given what we're seeing in the case activity in these hotspots like California that are really driving our case data. So, this is, really your domain here. But what we're also seeing is the test positivity data is showing that we're continually having all of the states, except for a very small few, with weekly changes that are increasing their case positivity for testing. And so I want you, if you could, Jennifer, to just walk us through what this means and what are some of the trends that you're also seeing around testing.
Sure. So we track test positivity to give us an indication if we're doing enough testing to find the infections that are out there. Are we casting a wide net? And what we're seeing is that test positivity is increasing in nearly all states. What this tells us is that we are starting to, that net that we're casting is becoming smaller and smaller given the infections that are out there. And so despite massive effort in the US to expand the numbers of tests that we're doing, we still yet have to do many, many more tests because, our infection, the spread of infection has outpaced our efforts to expand testing. We are, as of late, over 1 million tests per day, which is a remarkable development. But our overall test positivity in the United States is pushing past 11%, which is at least more than double where we would like it to be at most. The lower, the better. One of the really worrisome trends that we've been noticing in the data is it seems like as of late, testing has plateaued a bit, or at least the rate of increase in testing isn't quite as fast as it had been previously. A lot of this is likely due to a dip that occurred around Thanksgiving, and we're just now starting to come back from that. But if these trends continue, if we do not continue to expand testing, our positivity is going to continue to go up as this virus continues to accelerate in the US, and it will mean that many more tests that we have to do. I think, we're also hearing some anecdotes about testing being constrained in some places due to supply availability and, increasing test turnaround, which is a very difficult situation to be in when we're in this very dire part of the epidemic response. We ideally want to be able to test as many people as possible and to get those test results back quickly enough to be able to act on them, to make sure that people who are positive know that they're positive and that they can stay home, isolate, and that we can start notifying their contacts. And so just to say that we are now starting to see some declines in testing in a number of states, which is worrisome. Don't know exactly why that is. Could be that they are relying on other types of tests that may not be captured in their testing data. That would be somewhat of good news, except that not having those data makes it really hard to track if we're on the right progress. Could mean that there's a decrease in people who are wanting to be tested. Given the case numbers, it doesn't seem like it's due to a need for testing. So this is really, I think, a worrisome development.
And so what we're seeing here is that, here are the states where we're seeing the actual testing increasing versus decreasing. We're definitely seeing those decreases really sort of regionally consistent in that sort of mountain time zone. And then even in these gray areas where we're seeing on the map, these are places where there are no change, so that we're not seeing that increase, where we're really want to track as we're seeing cases increases. We want to see also that testing increase, so that we have really a good firm understanding of what's happening with the disease. The last slide that I'm going to share is actually from our US map. We added not only vaccines since the last briefing, but we also were able to intake all of the hospitalization data that HHS released. And so this map is showing a concentration of inpatient occupancy, and where you see the denser colors is where you're going to be bucking up against some of that capacity. We also have in the data resources the ability for you to explore ICU capacity and really trying to encourage people to think about it, particularly from a public policy perspective. The mix of measures that you're looking at your case data, you're looking at your death data, you're looking at your testing data, but hospitalization is playing a key role, and understanding that hospitalization should be part of the decision-making calculus when you're thinking about opening or closing, or the sort of decision-making that you're doing in terms of your holiday travel and some of the other things that we're really thinking a lot about as we continue to watch these trends. So thanks, Lainie. That's our data wrap up. And I'll look forward with Jennifer to looking forward to any questions. Jennifer, any parting words before I hand it back over to Lainie?
Just that, I think as states are starting to act, we hope that some of these disappointing trends will turn around. And we know that, a number of states are, again, looking at how they're dealing with this at the state level through policy. So I do want to paint a picture that this trajectory that we're on right now is quite worrisome, but it doesn't have to be inevitable. And as state governments begin to take action, I do hold hope that we can turn these trends around.
Thanks so much, Beth and Jennifer. Before I turn to Bill, I want to remind our audience to please submit questions for our experts in the box at the bottom of the screen, and we will spend the second part of this briefing answering your questions. Bill, now I'm going to turn to you. We have a vaccine with an emergency use authorization. We have seen initial doses administered. It sounds like we are on the cusp of a second emergency use authorization. Please talk us through these latest developments.
Yes, thank you, Lainie. And so much has happened just in the past week since we met last Friday. But first, I just want to say how excited I am that the Johns Hopkins COVID-19 Resource Center now will be able to track vaccine doses and allocation and distribution. I think this is so critically important. So I'm very excited to see that and see how that evolves. So exactly as you said, Lainie, we now have emergency use authorization, CDC recommendations for the Pfizer messenger RNA vaccine. We've seen the vaccine distributed from the manufacturing site by the federal government to the states. And we've seen this past week the first Americans get vaccinated with the Pfizer messenger RNA vaccine. And what a wonderful milestone that is in our fight against this terrible pandemic. And you just heard how the situation, how terrible the situation is in the United States. So this whole process is not going to be without challenges and hiccups. We're already hearing that there may be some reduced allocation of the Pfizer vaccine to the states next week. About 2.9 million doses are allocated to go out to the states, and we expect that may be as high as 6.9 million doses by the end of this year. So far, things I think have gone pretty smoothly. We have heard about allergic reactions, some severe allergic reactions called anaphylactic reactions. This was not seen in any of the phase 3 trials, but for both the Pfizer or the Moderna vaccine. We first heard about this in 2 healthcare workers in the United Kingdom who received the vaccine, and then more recently in Alaska here in the United States. We still do not know what component of the Pfizer vaccine may potentially be inducing these severe allergic reactions. It hasn't resulted in any pause or delays in vaccinating individuals, but it is very important that the locations where people receive these vaccines have the capacity to manage these allergic reactions. The big news more recently is with the Moderna vaccine, also a messenger RNA vaccine. We heard earlier this week from the recommendations of an advisory committee to the Food and Drug Administration. That's called the Vaccines and Related Biological Products Advisory Committee, and they made recommendations to grant an emergency use authorization. And we're now waiting for the FDA decision on that, and that's anticipated today. People may know that there are actually 2 parallel processes to getting these vaccines into the arms of Americans. One is the emergency use authorization by the Food and Drug Administration. And then there's a parallel process with another advisory committee, the Advisory Committee on Immunization Practices. They're expected to meet this weekend to review the data on the Moderna mRNA vaccine. And then that needs to be approved by the CDC, by Director Redfield. So we're anticipating that in the coming days, we're going to have both an emergency use authorization and CDC recommendations on the use of the Moderna mRNA vaccine. As people know, the CDC has recommended that healthcare personnel and residents and staff of long-term care facilities be the first to receive these vaccines, although the ultimate decision is up to the states and local jurisdictions. We're expecting about 7.9 million doses of the Moderna vaccine by the end of this year. And there are reports that the U.S. government has purchased a second 100 million doses of the Moderna vaccine that will be rolled out in the coming months. A lot of people have asked what are the similarities and differences between the Pfizer and Moderna messenger RNA vaccines. There are a lot of similarities, and it's quite remarkable. They both share very high protective efficacy, around 95%, which is just truly amazing. And I don't think anything near what most of us expected in terms of protective efficacy. They both have quite similar side effects. And these vaccines are what we call reactogenic. They induce inflammation. There's soreness at the site of injection and some systemic signs and symptoms such as headache, muscle aches, joint pain, chills, and fever in some people. But these side effects are transient. They last anywhere from about 12 to 46 hours. They will go away without any long-term implications or sequelae. They can be uncomfortable and cause significant discomfort in some people, and some people may have to take a day or two off from work for that. There are some differences, however, in the vaccines between in their cold storage requirement. This has received a lot of attention. Many people know that the Pfizer vaccine requires for most of its storage ultra cold temperatures, -70, -80 degrees Celsius. The Moderna vaccine does have a less stringent cold chain requirement, and that can be kept for most of its lifespan at normal kind of freezer temperatures, -20 degrees Celsius, can be kept refrigerated for 30 days. So that will make some distribution of the Moderna vaccine easier, and we're anticipating that the Moderna vaccine may go out to many more sites, 3,200 sites, compared to just over 600 sites for the Pfizer vaccine. And some of that is due to the different cold chain requirements. The Pfizer vaccine does need to be reconstituted with a diluent, whereas the Moderna vaccine is kind of ready to go out of the vial. And we're anticipating that the emergency use authorizations will have slightly different age ranges. The Pfizer mRNA emergency use authorization is for individuals older than 16 years of age. The Moderna will be for individuals 18 years of age. Many people ask if they'll be able to choose which vaccine they can get. I don't think early on there'll be a choice. It'll depend upon what vaccines are available, where people can receive the vaccines. But perhaps down the road, maybe later in 2021, when there's sufficient number of doses for everyone in the United States who needs or wants to get vaccinated, maybe at that point people will be able to make a choice. But from my own personal point of view, I would get either vaccine based on the safety and efficacy data. There are still a lot of unknowns about these vaccines. We still do not know the duration of protection. That's just going to require more time in the studies and in the phase 3 trials and in observational studies to see how long the duration of protection lasts. And that's linked also to knowing whether or not there are any rare, unexpected long-term side effects. I don't anticipate that to be the case, but that's something that we need to follow. We still need to learn a lot more about these vaccines in special populations, particularly pregnant women, children, and people with certain immunocompromising conditions, whether the vaccines are both safe and efficacious in those populations. And we're going to learn more about that in the coming months. There's been some interesting discussion about whether we should be using a single dose rather than 2 doses to vaccinate more people early on. I think it's an interesting question, but more data would need to be collected on the efficacy, protective efficacy of a single dose and the duration of protection. But we did see in the phase 3 trials for both the Pfizer and Moderna vaccines some protective efficacy after a first dose. But the vast majority of study participants received a second dose 3 or 4 weeks later. Going forward, we're going to face a number of challenges in the allocation and distribution of these vaccines. I think we're already beginning to see some of this, and it's not going to be easy. And that's another plug for the vaccine tracking on the JHU COVID-19 Resource Center website. Another big issue that there's been a lot of discussion about is vaccine hesitancy and acceptance. And there are communities, particularly Black and Latinx communities, where we know that the pandemic has hit very hard and where there's been, for historical and justifiable reasons, less confidence in the vaccine and more mistrust of the scientific process. I can assure everyone that despite the speed of the development of these vaccines, no corners were cut, and we have safe and effective vaccines. But a lot is going to need to be done to ensure that people trust this vaccine and have confidence in it. And I hope we see that going forward.
Thanks so much, Bill. Brian, You've been a frontline provider since the early days of this pandemic. Given everything that you've heard in this briefing, and especially Beth and Jennifer's discussion of hospitalization data, what are you concerned about and what do you see as potential bright spots?
So I think the most concerning thing for all of us who are taking care of patients on the front lines is fearing that we might find ourselves in a position where we know what the right thing to do is medically, but we're not able to do it because we either lack the resources, we lack the personnel, we lack the equipment. And I think we're starting to hear stories from across the country where health systems have entered into crisis mode, where there simply are not enough ICU providers or ICU resources to take care of all the patients that we anticipate are going to become severely ill. And I think that's probably the thing that keeps most of us up at night, because for many of us in our career, we've never been in a position where we've had to be in those crisis standards and be involved in making those types of heartbreaking and difficult decisions. I'm also concerned about the frontline healthcare workers who have been at this in many parts of the country since February. We're approaching almost a year of taking care of these patients and seeing the impact on not just our colleagues and our healthcare systems, but on our communities. And it's very frustrating to look around and to see that we know what the right things to do are to try to protect our communities and to try to get cases down. But by and large, we've failed as a community in doing that, in protecting not just ourselves, but in protecting each other and the most vulnerable. I think the number of cases and deaths we're seeing right now, it's really just, it's heart-wrenching. And the stories that accompany each and every one of those cases is equally heartbreaking. And I think that takes a toll on everyone who's involved in both frontline care, but also in just thinking about the logistics and how to navigate COVID in every aspect of our lives. I think along those lines, the vaccine is a tremendous boost for morale for frontline healthcare workers. At our hospital on Wednesday, we started giving out the first vaccines. I just found out this morning that my slot will be Christmas Eve. So that's going to be an amazing Christmas present. And I think that provides us hope, knowing that we're hopefully close to the end. But unfortunately, seeing the light at the end of the tunnel also highlights how far we have to go and how much work is still left to do before we get there. So I also, it's encouraging that when you look at patients who are hospitalized, overall in-hospital mortality has dropped. So the number of people who die from COVID has dropped over time. A lot of that has to do with some of the therapeutics that we now are using widely, like dexamethasone for those who are most critically ill, and perhaps remdesivir shaving off some time for people to get better. They get better a little bit quicker. We've done a better job at protecting the most vulnerable in some areas of the country, which has helped. We're also just better at maneuvering in isolation environments. We're better able to deal with the ebbs and flows of critical illness while we're wearing special gear and have to navigate special safety protocols. But there's a limit to that. And I do really worry that as the number of cases and hospitalizations have started to rise, we're going to overwhelm those gains that we've made over the last several months. And we are going to see more people get sick and unfortunately pass away.
Thanks, Brian. I see we've had lots of questions come in, and to our audience, please continue to submit questions. I'm going to shift to our Q&A now, but we want to make sure that we get through as many as we can between now and 1 p.m. So, Bill, no surprise, lots of questions for you today. I'm going to start with vaccines. Once vaccinated, can you still spread the virus?
Yes, Lainie, this is a really important question. And the truth is we do not yet know the answer to this question. We're going to learn about this in the months going forward, both in the current phase 3 trials and we'll see some additional studies to look at this. What we know from the phase 3 trials is that both the Pfizer and the Moderna vaccine reduce illness. They reduce COVID-19, mild, moderate, and severe disease. What we don't know is whether people who are vaccinated can get asymptomatic infection and still transmit the virus. I anticipate that just given the impact of these vaccines on disease, that they must lower or it's very likely, I should say, that they lower the viral load and thus would have some impact on transmission. But whether they completely block transmission we still don't know. So that's going to be an important question in understanding the potential impact of these vaccines on the future dynamics of this pandemic.
Thanks, Bill. I'm going to stick with you for another question or so. When you get your booster in roughly 30 days after the initial dose, does that second dose, the booster, have to come from the same manufacturer as the initial dose of the vaccine?
Yes, and the answer to that question is yes. The Pfizer vaccine second dose, booster dose, is given 3 weeks after, the Moderna 4 weeks after. And we know nothing about what would happen if an individual got doses from two different manufacturers. I don't think it would be a problem, but the recommendation and all the data are based on individuals receiving the same dose. And that's why it's very important that we track that each individual who's vaccinated, we track which type of vaccine they got and really ensure that they get the same vaccine in the second dose.
Got it. Thanks, Bill. Jennifer, question for you. Is the worldwide rise in cases that we're seeing due to a variant strain of COVID-19? Or I'm sorry, I should say of the SARS-CoV-2 virus?
I don't think we have evidence of that. Yes, there has been a new strain, and how significant that is in overall transmission, I think, remains to be seen. But we're seeing surges all over the place in places that are not geographically, contiguous. I've spoken to various governments about their response and what their challenges are, and many of them cite the fatigue that their populations have been experiencing, just perhaps not adhering as much as they once had to the public health recommendations to not gather and to go to high risk, particularly indoor venues. So I don't think that that's what's happening. I think that it's more like our response and the relaxation of measures and our relaxation of our own vigilance, and the fact that some people have, must continue to work and be in environments, and it's harder for them to protect themselves.
Thanks, Jennifer. Beth, question for you about our new vaccine tracker. Can you talk about the cadence by which the data are expected to be pulled for the tracker? And also in answering that, can you speak about the difference between what we're able to show on our tracker or what we see on state dashboards and what's actually happening on the ground?
Sure. So the tracker itself is tracking right now just the doses administered. What you're seeing in the states like that have their own dashboards, Ohio, Michigan, Texas, Nebraska, Utah, West Virginia, Idaho, Washington, South Dakota, and Connecticut, they are showing a mix of different information. First, they're gearing up to show doses administered by provider. So we have the Pfizer data in some cases broken out. We'll see Moderna added to that. So you'll be able to see the level and volume of which vaccines are coming from where. They're also gearing up also to give us a little bit more details around who's receiving those. So we're seeing in some of the dashboards that states are sharing which populations of people are getting these early received vaccines. So we're seeing healthcare worker tallies. We're also seeing some states gearing up for more demographic breakdown of that data. So as we're keeping a keen eye to some of the data that we saw, that showed a lot of inequity around who was getting access to testing and who was having the most disproportionate effect of the disease, we're seeing states also taking into account here in the vaccine data. And then we're also seeing some states trying to break out those that are getting the administered, those that how many people are getting it versus how many doses are being administered, right? So that's going to be may harken back to some of our strategy around looking at testing over people or those people that are having testing encounters. And so it's going to be a mix of things. Again, this is like another great reason why we need a standard for how this data should be counted. The first efforts, though, I have to say, by these states are really impressive. They're trying to give as much information as possible. There's going to be some hiccups. I want to warn everyone that there's going to be some hiccups because this is all very new. The data is getting out there as faster than we've ever seen data from a government being produced. And so we have to give a little grace to those states that are doing that reporting. But I do think that it is a really good indication what we've seen so far in these early state dashboards.
Thanks, Beth. Brian, question for you. We've heard in this briefing about overburdened hospitals and concerns about ICU capacity and the potential for emergency and crisis standards of care to be implemented. Can you speak to what we know about how many, or even just how, states and communities have established protocols for these potentially altered standards?
Sure. So, and it's very important to recognize that these are very local and regional plans. So many hospitals and health systems have had for years plans for crisis standards of care, particularly around things like mass casualty events, but particularly around infectious diseases. I think, beginning back with SARS in 2003, 2004, and then with pandemic flu in 2009, many health systems had policies in place to what would we do if we ran out of ICU beds, if we ran out of ventilators. But it's been even a more coordinated process than just a single health system deciding. These are decisions that are made from health systems, but also in conjunction with local and state health departments and governor's offices to really kind of set benchmarks for when would these standards go into place. And what would be the metrics that we would use if we were in a position where we had more patients who needed an ICU bed than we had beds available, or if we had more patients that needed a ventilator and we didn't have enough available. And so there are certain themes that underlie a lot of these proposals, but they actually do vary quite a bit from state to state. And so, here in Maryland, for example, there's a group of hospitals that have gotten together to work on what some of these policies might be in conjunction with the governor's office. And I imagine most other states have similar protocols that are in place.
Thanks, Brian. Bill, a two-part question for you about seniors and vaccination. So first, in terms of likely distribution, when will those who are over age 80 likely be able to get the vaccine? And then the second part of that is how will folks learn about the availability of the vaccine, and is the expectation that they'll have to have an appointment, wait in a line somewhere? How's it likely to roll out?
Yeah, so these are very important logistical questions. And just to reiterate again, a lot of these decisions are being made at the state and local jurisdiction levels. The way the allocation process is kind of laid out, and these are federal guidelines again, so the states can modify these, is that after healthcare personnel and residents and staff of long-term care facilities, the next phase will include some essential workers, and that still needs to be defined at the state level. Individuals with comorbidities, other underlying diseases that place them at high risk of severe COVID-19, and individuals over the age of 65. So there's still a lot, the devil's really in the detail. And as Brian was saying, a lot of this decision making is really done at a very, very local level. But I anticipate that in the first, I'll say 2 months or so of 2021, we'll move into that second phase, and where the essential workers, individuals with comorbidities, and older adults over the age of 65 years will become eligible for vaccination. Now that, as the questioner kind of points out, that does raise challenges about, how we're going to identify people who are eligible in that phase and notify them. And some of it will be done through, I think a lot of it will be done through private practitioners, but also pharmacies will be able to play, I think, a key role in notifying individuals of their eligibility, as well as just more general communications that come through the departments of health in individual states. So it's going to be a mix of different kind of messages, and there, as Beth said, there are going to be hiccups going forward and challenges. But that's kind of how I see it in the early months of 2021.
Thanks, Bill. Jennifer, question for you. Given the population of the United States compared to other countries, is it a surprise to you that we're seeing more cases in the US than anywhere else?
Yes. We have about 4% of the world's population and about 20% of the world's cases. So we are over contributing to the global case numbers. And, it's a really disappointing situation to be in, because I don't believe that the United States lacks knowledge of what needs to be done, or even resources in order to be able to not have gotten to this point. So how poorly the response has gone in the United States was very surprising to me, as someone who has studied countries' readiness for these events. We've just really underperformed.
Thanks, Jennifer. Bill and Brian, you may want to tag team on this one. What do we know about vaccine distribution for healthcare workers outside of the hospital setting at this point?
Brian, do you want to take that, or?
Sure. I mean, I can tell you that here we focused on frontline providers in the hospital, because that's where the greatest number of providers are, and perhaps the greatest need right now. And so, each health system has been given allocations from, in our state of Maryland, has been given allocations from the state government, and then determined a process by which we can then fairly and transparently give those vaccinations to the frontline healthcare workers. But it's going to be weeks to months before all of the hospital workers who are in patient-facing and critical infrastructure positions are going to be vaccinated. I have not yet seen plans specifically for non-hospital-based workers within that, who aren't doing, either direct COVID care in their clinics or home care with COVID patients who have been included in that front line.
Yes, and I would just add, I agree with what Brian said, and the intent here is to preserve a functioning healthcare system. So, and that includes obviously healthcare personnel who are working outside of hospital settings. So they are included in at least conceptually in that first round. But when that'll actually happen, I agree with Brian. It's probably going to be weeks until sufficient vaccine doses are available to reach more broader healthcare workers.
Thanks to you both. And additional question that you may want to tag team on, but I'll send it first to Brian. We've heard the word comorbidities come up a few times in this briefing. Can you talk us through that a bit, specifically for COVID? And is there a particular list somewhere? How do we know what we should be thinking about in terms of COVID and comorbidities?
We're still learning. We're still, despite being almost a year in, we're still gathering data on who are the patients who are at the greatest risk. So there's a couple of different ways that you can look at comorbidities. You can look at composite sort of comorbidity indexes or scores for someone, which sort of weights, gives certain comorbidities like diabetes with kidney problems a little bit higher of a point than someone who has heart failure. And certainly cancers factor into that. And so you can look at weighted scores. And if you look at that, people who tend to have a higher number of comorbidities or more severe comorbidities tend to do worse with COVID, particularly when you control for age. But if you look at specific comorbidities, we know that patients with end-stage kidney disease or chronic kidney disease are at particular risk. We know that patients with poorly controlled diabetes are at risk. Patients with underlying heart disease are certainly at risk. Patients with chronic lung diseases are at risk, and certainly patients with malignancy. So those tend to be the ones that we're most worried about, but it's not necessarily one particular comorbidity. It's really all of the things that someone is dealing with, both from their medical history, but also we know that the risk of getting COVID is also tied to what community you live in, and as Bill mentioned, particularly Black and Latinx communities have been hit particularly hard in terms of their risk of contracting COVID.
And Bill, thanks, Brian. Bill, any additional thoughts about COVID vaccines and comorbidities?
Yeah, so this is, again, the intent here is to protect those who are most vulnerable, as Brian said. But I think this is an example where, sometimes the higher level, maybe federal guidelines are stated quite broadly, but the devil's really in the details. And it's going to come down eventually to the states. And these are going to be really tough decisions. really hard decisions to make about, which, individuals with which of these comorbidities or combination of these comorbidities are really going to be prioritized and first on the list to get vaccines. So we have these higher level recommendations, say from the federal government or from the National Academies of Science. But there are going to be some difficult decisions made as hospitals are making with healthcare personnel. They just do not have sufficient doses to cover everyone who's eligible in that group. So hard decisions need to be made. So we're just going to have to see how that plays out at the state and local jurisdictions.
Thanks, Bill. Beth, a couple of questions coming in about our new vaccine tracker, and I want to thank our audience for their enthusiasm about it. And of course, we want to answer your questions. So first up, can you talk through whether we have data from all 50 states or just those that are currently highlighted in blue on the map that we show?
Yeah, so it's just those states that are highlighted in blue on the map where we have their sort of cumulative dose data. And that's all we have is Pfizer data because those are the ones that are out in the market. And that's what is being reported. We're pulling this data directly from the states. So we're really dependent on the state reporting. And you can also source that data and that is open. So if there are those people who really want to dig into that data, it is available by link when you are on those region pages looking at the vaccine data itself.
Thanks, Beth. And we've gotten a few questions along the lines of what I'm about to ask you, which is going forward, how do we plan to approach the issue of separating out doses administered, since we know at least for the Pfizer and Moderna vaccines, it's 2 doses till you're considered fully vaccinated versus individual people who have been vaccinated?
Yeah, I mean, I think this is the big question that we've all got our eyes on. Right now, they are tracking the doses that have, these are shots that have gone into arms this week with the very first round. You can see in a lot of the states that they're poised to really to measure both things. So to have each dose measured separately. I'm really hoping that we're going to get some standards around how that data should be collected and how it should be shared. It will be really important to know not only who's getting the boosters, making sure that the number of people that got the first round are getting the second round to understand the delta between those things, but really we want to know the people who have been vaccinated, which requires both of those shots. And so we'll be working with the states as they are releasing this data, but really hoping that we can get some of that standards led from HHS and the way that they've been distributing the hospitalization data.
Thanks, Beth. And I think I can speak on behalf of all of us at the Coronavirus Resource Center when I say we are exquisitely sensitive to exactly this issue and to ensuring that our data are both complete and accurate. Jennifer, question for you about testing. How does the US compare relative to other countries and testing? And specifically, if the US is testing more, could that impact the number of cases that we're seeing?
So we track international testing trends also on the Coronavirus Resource Center on our testing portion of the site. And what we see there is that the US does perform many more tests than other countries, a number of other countries, and many more tests per capita. That said, to the question of, I think sometimes there's a belief that we only have as many cases as we do because we're just testing more than other countries, and that is not true. And the reason why we know this is because we also track test positivity, so the percentage of tests or the percentage of people tested that comes back positive. And what we've seen is that the United States, particularly right now, has a much higher test positivity than a number of other countries, and so we are actually under testing by that metric compared to many other countries. We're probably missing a lot more infections than countries that have a much lower test positivity. There's some countries whose test positivity are, not only below 5%, but even below 2%. So that means they are casting a much wider net to find infections than we are, and so we can't just explain away our large case numbers simply as an artifact of testing. That said, I think there are a number of other countries that are not testing as much as the US, and they would have larger case numbers, but I don't necessarily believe that it would completely flip our status as lead in terms of the size of our epidemic.
Thanks, Jennifer. So we're coming up on 1 p.m., but I want to close out this briefing by asking each of you just in 1 or 2 sentences to answer a question for our viewers. And Brian, this is going to come to you first. So what is the best advice that you can give as we head into the holidays in 2021, especially for folks who are now thinking about how to get through these long winter months ahead?
So there's a Scandinavian saying that's also been attributed to Alfred Wainwright, who's a British naturalist. And the saying goes, there's no such thing as bad weather, only unsuitable clothing or bad clothes. And I think people need to be really mindful, particularly about the risk of being indoors with other people. We know that that's a particularly high risk activity, particularly if you're taking masks off and eating and drinking and laughing and enjoying each other's company as we want to do. It's not safe to do that right now, given how widespread the virus is. And I think you really need to pick your activities carefully and where possible, stay outside if you're going to be gathering with people who have not been in your immediate household or immediate exposure risk.
Thanks, Brian. Bill, same question to you. So best advice as we head into the holidays and folks think about how to get through these long winter months.
Yeah, so I think, we've talked a lot about the vaccines that we have already that are coming down the pipeline. And for me, that's a big ray of hope that we can see the end of this, but it is still a long way away. But we have now an additional tool in our toolbox to fight this pandemic, a very important tool. And so I would say, just echoing what Brian said, we need to get through these very difficult months coming ahead, including the holiday season, and protect ourselves, protect the people around us, protect our loved ones. And we will get through this, but this is the time to really buckle down and follow the public health practices that we know can stop the transmission of this virus until we are able to really vaccinate a large proportion of our population.
Thanks, Bill. Beth, over to you. Same question. Beth, best advice for getting through the holidays and the next couple of months.
Yeah, I think that, this is not the time to give up. I know there's a lot of fatigue out there, but the data is telling us, and I'm a person that really believes in lead with the data, and it's telling us now's not the time to have the party or to get together with the family, but to follow all of the good advice that you're getting from your mayors and your governors around staying home, limiting your public interactions, wearing your masks, and really just being mindful. It is an exceptional year. It's been an exceptional year. Like, we just need to see our way through the next several months. And there is now light at the end of the tunnel, which is so exciting. Who would have ever thought that we would be able to be at this point so soon? So it really is just getting through these last several months.
Thanks, Beth. And Jennifer, I'm going to give you the last word before I close it out. So best advice for heading into the holidays and getting through the next few months.
I like Brian's suggestion about the appropriate clothing. And, I understand how incredibly hard it is to forgo seeing loved ones, during holiday times. I think we just need to find ways of connecting with each other that are safer, and, outdoors activities is a good potential way to do that. It's so essential that those of us who can do try to live as safely as possible, because we know that there are people who still have to show up to work and are on the front lines. And, I think it's our responsibility to make it as safe as possible for them. And when we take unnecessary risks, it does make it hard for other people who we depend on to power society and to save our lives when we get ill. So I think that's a good message for the holidays, which is try to do our parts and try to find other ways to connect with our loved ones.
Thanks, Jennifer. I'd like to thank Beth Blauer, Jennifer Nuzzo, Bill Moss, and Brian Garibaldi for joining me today, and to give a big thank you to everyone who joined us and those who submitted questions for our experts to answer. As always, this briefing will be archived and available on coronavirus.jhu.edu. I also encourage you to check out our newly launched vaccine tracker on the site. And from all of us at the Johns Hopkins Coronavirus Resource Center, we hope that you have a happy and safe holiday, and we'll look forward to seeing you at our next 30-minute briefing in early 2021. Thanks.